All right. Good morning. Thank you very much for having me. I'm Anahita Dua. I'm a vascular surgeon at the Mass General, and I'm very excited to be talking to you about DVA. Well, the computer's not excited for me to be talking to you about DVA, though. What's going on? There we go. All right. Some disclosures. We all know right now, big epidemic of diabetes that's basically destroying our patients' legs and lives. And we know, of course, everyone's familiar with this graph, that it's a big deal because if these patients get amputated, the mortality rate is significant. And this group of patients, even though we're so much better at medical therapy these days and patients are really doing overall better in other realms, unfortunately, amputations are on the rise in spite of all the shoes at Foot Locker, which means that something is going wrong, and what we have out there is not enough for these people. So what I'm going to do with you today is talk to you about two things: deep venous arterialization and wound therapy, because they're interlinked. You can't really do one without the other. Basically, we all are aware of this 200-day rule that was published, actually, that says in a diabetic patient, you need at least 200 days of good flow for a wound to heal. So even if you get a wonderful angiogram at the end of it, it doesn't matter unless that stays open nicely for your patient to heal. And in these types of patients that have the desert foot, unfortunately, that's not possible. So what happens to them? We try, we get an okay angiogram, usually it recoils, and by the time you've finally done that chop, 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 in a year, the patient's leg is gone, and a year after that, they're dead. So is there anything else we can do for these patients that have this total microvascular dissemination? Well, the answer is yes. Deep venous arterialization is the way to go. But before you can even begin to think about it, you have to pick the perfect candidate. So who's the perfect candidate? Well, patients that have, quote, bad disease, bad as in big artery disease. And when I say big artery in this case, I'm talking tibials. These are not good patients for DVA because you have an option. In a patient like this, however, where let's say you get that AT open, but there's nothing going out to the foot, this is a SAD patient, small vessel disease, tibial disease. And in this patient, DVA is the way to go. So bad patients, you don't need to do anything because you have conventional options, including bypass. SAD patients, DVA is an option. So let me show you a couple of images. First of all, how we do the procedure, and I am going to go through it step by step. Essentially, all you're doing is making a fistula. Truly, a monkey can do this procedure. It is the easiest thing ever. We're selling it as something that's super difficult because we want to get on podiums, but really anyone can do it, okay? What is hard is the wound care afterwards and taking care of these patients. So I'm going to show you a quick video here for the people who have not seen this before. You get ultrasound access to the lateral plantar vein in the foot, and you put into the PT vein or the perineal vein, depending on what you're going to use, this catheter, and this comes as part of a kit if you're getting the lymph flow kit. Then you come from the groin, antegrade axis, and all the way down into essentially your donor vessel. Now, your donor vessel can be the PT artery or the perineal artery. You can use the AT, but it's difficult because the throw of the needle is only 1 centimeter. And then you make a fistula. That's the snare opening there, and now you're going to see a needle shooting from the artery into the vein. And here comes that needle. And then from the back of the antegrade axis, you put a run-through wire that can then be snared and then pulled through and through axis. So you're going from the artery up top into the vein, out the foot, and then you can just fly because it's very easy to just put devices up and down. You end up putting a valvulotome in to break up those valves, which is why this kit is great because it has that forward-facing valvulotome. Then you balloon the whole thing, lay stents down to the calcaneus, and then you're good to go. This is that valvulotome. My God. Okay, it doesn't take that long to do. And then you put your stents in. And what you see, this is the money shot really of the talk. So if you look at the baseline, right, you see no flow in the foot. The acute result is also not good enough. For those of us who make fistulas, you know you can't send a patient for dialysis as soon as you make that fistula. You have to wait, right, for it to mature. Same thing. Doing the DVA is just putting seeds in the soil. You then have to wait 3 months at a minimum before you can go and do a TMA. So as you notice, from 45 days to 90 days, the patient has lost their toes. Notice that? And then, of course, you have enough flow to be able to heal. So this is a real case, and that's why I wanted to show it to you, because the point here was to show you the tips and tricks and how to do the procedure. This patient of mine, that toe there, I'm from MGH, I said, so that's like a Boston cream pie right there, full of pus, okay? So real patient, took him to the operating room, took the toe off in the middle of the night. Next morning, do some PVRs and a check. He's completely flat. And no, we did not do the dead toe. We did the second toe, even though it says first over there. We then decided the patient was good for a DVA, took him to the operating room where we put a tourniquet on their ankle, and then we get lateral plantar access to begin. And that's the location that we do it in. You can see a hockey stick probe to be used. And the most important thing here is if you don't get the venous access in 3 tries, really you should stop, because the foot will swell with the tourniquet on and you stabbing it, and you'll lose your access completely. You turn the heat up to the point where your residents are calling you profusely sweating, and that's when you know you're ready to go. Put the tourniquet up only at that moment, use a hockey stick probe, and get into that lateral plantar, which will be really plump for you. I use a regular micropuncture needle to get through. And then after that, I put a 4 French sheath in, and you're good to go. Everything's on an 014 system. Then go up to the groin, get your SFA access, and I put a 45 centimeter 7 French sheath in, all the way down to the groin. After that, we do a shot to make sure that we're actually in the veins distally. Then I put a V18 wire up. You can see that in the PT vein there, and you can see the PT artery is just that little remnant. So that's my donor vessel. I then put my crossing catheter down, antegrade axis, fire a needle across, and then balloon that fistula. That's ballooned with a 3.5 balloon. And after that, you're going to immediately get your fistula. And then you've got your through and through access with the snare, and ultimately can drop your stents, as you can see, to the calcaneus. Nothing happens if you go a little bit further. You're not going to compress those stents. And if you don't have it in the lymph flow kit, you can use 5 Viabonds to go as far out as you want. But don't put it too much into the plantar loop, because otherwise you will lose what you're going to be using to create that neo-revascularization. And ultimately, this is what you end up with immediately, all the way around. And then what we do is we sneak past where we've actually inserted into the foot and put a Hydra ST wire all the way around and balloon it with a 3 or 5 balloon. Now, we get toe pressures essentially 3 to 4 weeks afterwards, but you're not ready to go, and this is what your patient in reality will look like, right? Because we took that toe to begin with. And what you want to do now is hold the course. Everyone and their mother will call you, you need to amp, he's getting sick, he's in pain. Just hold the course. You will know if the patient is septic. Hold it for 3 months. At the 3rd month, that's when the patient is ready for you to do an open TMA. It'll bleed like crazy. Again, control yourself. Do not close this. This is not an artery. If you do close it, the actual foot area will die because veins cannot take the sutures. So you leave it open. I usually put a piece of Stravix, which is the amniotic tissue, and hopefully that's covered. You can ask Dr. Jen about that. Mm-hmm. And then I put a vac on top of that, really low suction. Just 75, you're just getting a bed of granulation tissue to ultimately skin graft the patient. This guy is now 2 years out, runs all over the place. So it's really successful in the patients that you pick appropriately. So most important things, again, you want to wait that 3 months. You don't want to use sutures, and you really want to collaborate with your podiatrists or your plastic surgeons. Aside from the fact that collaboration is nice, these are also very painful patients, not for them, for you. Multiple phone calls, so if you don't have a team, you can't do it because you won't be able to do anything else. I've only put this slide up here to just show you over time what you need to do. And if you want to take a picture of it, you certainly can take a picture to see. One thing to tell you quickly, your live case is ready. That's what I'll tell you quickly. Okay. This is just the last thing to say is you don't always have to take the toes. As you can see here, there's bone sticking out in this guy, but his toe pressure went from 0 to 64 with the DVA, and he healed. So I'd say about a third of the cases, depending on when they come to you in the spectrum of things, that's when you go ahead and take the toes. But most of these patients, I'm actually doing even with rest pain. I don't know, Dr. Say, if you're doing it too, and Dr. Dipple, but we're really moving it up. And the only reason that we included patients with wounds to begin with is because that's how the PROMISE study was designed for the FDA, not because it's necessarily the right thing to do. So if you have a patient that you think you can do a DVA on, that you need something to last, like in a 56-year-old, it really is the right thing to do in the right patient. Okay. Thank you.
Thank you.